Glad to have you joining everyone today. My name is Anissa Mitchell. I'm with PMD Alliance, and you are actually joining us today for a program specific to our Proactive Brain Health Alliance programming. And today we're going to be talking about REM sleep behavior disorder, RBD for short. You probably have heard that, whether it's an early sign of Parkinson's disease. And if you have joined any of these proactive brain health programs before, you might know that we have started this year in 2024 to offer those who might be at risk or have already been designated as having a prodromal symptom, such as REM sleep behavior disorder, looking for some specific information on that and how to maintain brain health and how to be proactive in that. So we're so happy that we have this space, and we're so happy that we're able to have this program today. I've been very interested in this topic for quite some time, so I'm very excited to have our expert today, Dr. Michele Tagliati. He is a movement disorder specialist and the director of movement disorders programs at Cedars-Sinai Medical Center in Los Angeles. He is also one of the nation's leading research and treatment specialists and experts. He's been in the field for over 20 years, and so we're so thankful to have him with us today. And he is going to be sharing some slides with you, and feel free to ask your questions in the chat, and then we'll get to those at the end. We'll keep track of those for you. And I'm also going to let you know today, at the end of the program, we do have a couple of short questions for you, 2 poll questions, to kind of help us know how these programs are impacting and helping you. And then another opportunity to give us a deeper dive of information. So we'll address those at the end. And then I'll tell you about some additional things that are available to you. But for right now, I want to welcome Dr. Tagliati, and I want to hand this over to you.
Thank you, Kelly. Thank you, Anissa, for this kind presentation. I'm going to try to share my screen so we can start. Let me see here. Can we all see this?
You're good to go.
Perfect. There you go. Perfect. So, the topic today is REM sleep behavior disorder, also known as RBD, and its role as an early sign or prodromal symptoms or risk factor of Parkinson's disease. Let's see. There you go. So this is nothing new to this audience, but Parkinson's disease is now defined as the fastest growing among neurological diseases. We noticed that the number of individuals with Parkinson's disease has doubled, more than doubled since 1990, and is expected to triple by 2040. So it's going to become an enormous public health challenge. And the good news in this, the silver lining, is that the knowledge about the disease is also changing and growing and improving, and that is changing our approach to the disease. So let's go back to the basics here. This is the classic definition of Parkinson's disease. At this point, we can call it the old definition of Parkinson's disease: the progressive chronic neurodegenerative disease characterized by 3 typical motor symptoms, right? We all call movement disorder specialists: tremor, rigidity, bradykinesia, presence in various combination, with the slow and selective loss of dopamine neurons, accumulation of Lewy bodies in the substantia nigra, and a good response to levodopa or other dopaminergic treatment. This is what we have been teaching and reading for probably more than 100 years. But over the past 10, maybe 15 years, we have been seeing what I call the non-motor revolution. What does that mean? It means that we started to realize, this is probably the iceberg picture that all of you have seen 100 times, that while we look over the surface of all this typical motor symptoms and complications like dyskinesias and difficulty walking, there are a number, many other non-motor symptoms that are equally frequent, if not more frequent, and definitely more disabling than the motor symptoms. And that has forced all of us experts to reconsider what is Parkinson's disease in reality and try to obviously take this knowledge into account. This is because non-motor symptoms not only are very frequent and they're very disabling, but very importantly can precede the onset of what we call Parkinson's disease, the tremor, the rigidity, the bradykinesia. Sometimes even by 20 years, this is an old illustration of Dr. Brack showing, for example, the constipation or loss of smell can precede the symptoms, the typical symptom of Parkinson by 20 years or more. This is very important because it started to raise the question of when does Parkinson's disease really start? Does it start when we see the first tremor or the first lack of dexterity or the first stiffness, or when we have these symptoms of loss of smell or constipation, or as you see, RBD, REM behavior disorder? When does Parkinson really start? And we have now, over the past several years, noticed and studied that all these symptoms, loss of smells, sleep problems that we'll see in detail, constipation, depression, anxiety, are seen very frequently in the early phases or in the very early phases before the symptoms occur. And REM behavior disorder as a specific place here because it's the one with the highest specificity, meaning it's the one that is most frequently actually associated with the development of Parkinson's disease. In other words, people can lose their smell, being constipated, being depressed, but not necessarily end up having Parkinson's disease. Well, this REM behavior disorder has a very high risk of developing, over 65% chance of developing after sometimes into Parkinson's disease. And this is Carlos Schenk. He's a psychiatrist in Minnesota, the University of Minnesota, which in 1996, you see, not that long ago, less than 30 years ago, came up with this observation that these people with this specific problem with sleep, this acting out of their dreams, seem to develop Parkinson's disease in very high and unusual percentages. So you see 40% of 29 patients at 50 years or older develop Parkinson's disease about 13 years after the onset of RBD, which increased to 65%. And here on the right, under the picture of Dr. Schenk, you see this Kaplan-Meier curve, which is a curve that shows you how many people actually develop Parkinson's. And you see if you wait up to 15 years, pretty much everybody who was diagnosed with REM behavior disorder develop Parkinson's disease, which raised the big questions like, is this a risk factor or is this just the first symptom of what we then call Parkinson's disease? And not only that, if you if you associate the REM behavior disorder with the loss of smell, in particular with the constipation and many other symptoms that have been associated with the early stages of the disorder, the chance of having Parkinson increase exponentially. Look at these numbers: 33, 160 times the risk, 1,200 times the risk. To me, 1,200 times the risk is not a risk anymore. It's just the beginning of the disease. So what is REM behavior disorder? Because this is not a diagnosis that normally neurologists tend to deal with. This is a sleep specialist type of problem, which, however, now is becoming more and more frequently addressed, at least in the neurological clinic. So what is REM behavior disorder? In order to understand what is REM behavior disorder, we need to go a little bit back and review how we sleep at night. So the typical 8-hour sleep cycle, we fall asleep and we slowly go through this stage 1, 2, 3, 4, which are deeper and deeper sleep, which is something that is intuitive, right? Our sleep becomes deeper with time. So within 1 hour, we reach our deepest sleep, but then we don't stay there. We don't keep on sleeping deep through the night. We actually start cycling. We start going back to a lighter sleep. Some people actually wake up here and there, and then we go back down to a deeper sleep, and then we go back up. And these cycles repeat several times during the night. And then at some point on the way to a lighter sleep, there is a so-called REM sleep, so rapid eye movement sleep. What is that? It's actually a paradoxical stage, because instead of kind of slowing down, the brain seems to activate, seems to become more active. And it is the stage in which we actually dream when we dream. And I brought you a little video to show you why it's called REM, rapid eye movements, because this is a person who is sleeping, but you see that she moves the eyes right and left, and she brings, and interestingly, even though the brain is clearly very active, she's completely paralyzed. That's why we can dream to climb the Everest without literally moving a finger, and probably many of you have experienced not being able to run or to move during their dreams, because we are literally paralyzed. The only thing that we can move are the respiratory muscles, fortunately, and the eyes, as we've seen in this video. However, if you develop REM behavior disorder, something unusual occurs, because instead of this atonia, instead of this paralysis, we start acting out the dreams. You can see it in this gentleman that is in the sleep lab, and you see he's like waving his pillow, is clearly agitated, he's clearly fighting with someone in his dream, probably. If he was not belted to the bed, he would probably fall off the bed. And in fact, this dream enactment may be simply talking. Many people talk in their sleep, but it becomes more violent, shouting, punching, kicking, jumping. People get hurt, they fall off the bed, or they can hit their bed partner. And this is commonly seen in older males. It's relatively rare before age 50. Although there may be, I was reading a sleep study, gender bias, meaning that men tend to agree more often to do a sleep study as compared to women. Independent of that, the way we diagnose or a sleep specialist at this stage diagnose REM sleep behavior disorder is with a clinical evaluation, literally asking the patient or their bed partner whether there is a history of acting out dreams, of talking, of screaming, or punching during the sleep. Then we can do a PSG, a polysomnography, so a sleep study, in order to literally videotape and record the brain waves during sleep, and see whether those cycles are interrupted by this muscle activity, this unusual and abnormal muscle activity. And we need to figure out whether there are other conditions. For example, some antidepressants can stimulate this REM behavior disorder. In that case, we call it a secondary, not an idiopathic REM behavior disorder. And there are some interesting questionnaires that, if we don't have the time or the resources to have a sleep study, we can ask some of this simple question. And if more than 6 of this simple question are a yes, then the chance that the patient has a REM behavior disorder is extremely high. And what we can do about it, well, we can treat them with melatonin over the counter. That's usually the first and easiest way to try to slow down this acting out of the dream, or a stronger medication like clonazepam, which is a benzodiazepine. We can have some behavioral strategies trying to make sure that you know, the environment in the bed is safe. Some people, as we saw, they may put a belt in order not to fall off the bed, and obviously follow up and make sure that the treatment enacted are effective. But this is more of a sleep specialist. So what is the relationship? Why are we so interested? Why Parkinson doctors, Parkinson specialists are so interested in this RBD? Well, because what we learn about sleep and REM behavior disorder tell us that basically there are two mechanism in the brain. One that sort of sends to the cortex the activity that sort of then translates into the dreams, into the increase and not very sleep-like activity of the brain. But at the same time, we have a bunch of nerve fibers that go down and tell the rest of the body to stop moving, to be paralyzed. And so people that study REM sleep behavior disorder saw that there are a number of reasons. You see the antidepressant that I mentioned before, and neurodegenerative disorders, including Parkinson's disease and severe stress, other issues that can cause the RBD. Obviously, what we are interested is Parkinson, and from what we know about the progression of Parkinson, Dr. Brack 20 years ago showed that and hypothesized that Parkinson's disease may actually not start in the substantia nigra, as we've been told each other for many years, but it may start much deeper in the brain, in the dorsal motor nucleus, the vagus nerve, or in the olfactory nucleus, and then ascend up toward the cortex, and on its way sort of hit the substantia nigra with all the dopaminergic deficits. But the second step of this hypothetical progression is exactly where the REM behavior disorder and the sleep in general is regulated in the brain. So if the disease so early, so even before the substantia nigra and the dopamine neurons are affected, can dysregulate the sleep, and in particular the REM sleep stage, here we are probably able to explain why so many people that develop REM sleep behavior disorder after a number of years then progress to develop what we have been called Parkinson's disease for over a century. But let's see a little bit more detail. So this is the new, you see, published in 2024, so only a few months ago, the new proposed biological definition of Parkinson's disease, which is trying to get away from the simple description of the symptoms and describe more of the biology, what is really happening inside the brain and the body in general of patients with Parkinson's disease. And you see that in this definition, a stage 2A and 2B, REM behavior disorder, you see here, RBD, is already considered basically a symptom of Parkinson's disease, not a neurological symptom. It's considered a subtle clinical sign or symptom that can be motor or non-motor, and you see the loss of smell, hyposmia, RBD, and so forth. And what are the biomarkers that we need to look into are basically three. One, the deposition of abnormal alpha-synuclein. I'm sure you're all familiar with the term alpha-synuclein or synucleinopathy. That is one of the ways to describe what happens in the brain of Parkinson's disease. Neurodegeneration, obviously the loss of neurons, in particular dopaminergic neurons. And also now we're paying a lot of attention to associated genetic factors. So let's see if RBD can sort of fit this description of Parkinson's disease. So we know that GBA, which is one of the mutations most frequently associated with Parkinson's disease, is also frequently associated with RBD, maybe not surprisingly at this point. So you see that those who have GBA mutation have a risk of developing RBD, which is 6 times normal. So very, very high. And among patients with Parkinson's disease, that is is still very high, still 3 times those patients that don't have a GBA. So RBD is associated with GBA mutation. And so combining in the future this genetic information and the diagnosis of RBD may assist researchers and doctors in identifying people that are prone, that are going to develop the neurological symptom of Parkinson's disease ahead of time. And as we will see, at least try to treat them ahead of time. This is a DAT scan. So here we're trying to see whether there is neurodegeneration in patients with RBD. And the answer is that unfortunately, yes. And these are in the bottom, you see the DAT scan, and you see the smaller and smaller yellow red dot that represented the dopaminergic terminals in the basal ganglia. And this is a patient that started with RBD and then progressively developed Parkinson's disease. He was diagnosed with Parkinson's disease. So, of course, it's not surprising that the DAT scans slowly deteriorated. But the 3 scans on the top are of a patient that remain disease-free over 3 years. But you can see, you don't need to be a radiologist to see that these areas of dopaminergic innervation are progressively getting smaller and smaller. So we can imagine, unfortunately, that if we wait another year or 2, probably also this subject will develop Parkinson's disease. So REM behavior disorder is also associated, even without the symptoms of Parkinson's disease, of what we now call Parkinson's disease, is associated with the neurodegeneration. Last but not least, alpha-synuclein. How do we decide if someone has a synucleinopathy? Well, of course, we have seen accumulation of alpha-synuclein autopsy. I'm sorry, I did something wrong. We have seen accumulation of alpha-synuclein in the brain of patients with Parkinson's disease, but we can now do it during life, doing a spinal tap, studying the cerebrospinal fluid. And with this very new and advanced and very specific technique that is called alpha-synuclein amplification assay, we can figure out whether patients with Parkinson's disease or at risk for Parkinson's disease or suspected to have Parkinson's disease have indeed the abnormal synuclein, the phosphorylated synuclein in the CSF. So when we do this in patients with REM behavior disorder, this is just one of the many studies that went to look for alpha-synuclein in the cerebrospinal fluid of patient with RBD. And you can see a very high percentage, 93%. So more than 9 out of 10 patients with REM behavior disorder and no symptoms of Parkinson's seems to have already abnormal synuclein in their cerebrospinal fluid. Another way to look for the synucleinopathy is a little bit simpler. It is to have a skin biopsy. So instead of sticking a needle and getting a spinal tap, which is something that many people are not exactly excited to have, we can take a little piece of the skin and send it to a lab in Arizona, where they can tell us whether they find abnormal deposition of phosphorylated alpha-synuclein in the peripheral nerve, in the skin nerves. And this is found to be very sensitive and very specific to diagnose Parkinson's disease. But recently, we have been involved in a study of patients with REM behavior disorder without symptom of Parkinson's disease. And I'm going to show you something that comes from literally from my personal database. These are the first 9 subjects that we tested with the skin biopsy, and you can see that 7 out of 9 have an abnormal skin biopsy. So only 2 had no abnormal alpha-synuclein in their skin. And we don't know, obviously, if these will develop. We will biopsy them every year for 3 years, and so we'll see if there is an evolution. But already at baseline, most of our patients with RBD and no symptom whatsoever, neurological symptom of Parkinson's disease, seems to have already something going on that we can detect only with the skin biopsy. Having RBD and other factors is not just a curiosity, or it's not just a way, which is obviously very important, to detect it early. But having RBD is important because it changes a little bit the complexity and the prognosis and the expectation of how the disease might progress. So you can see that if there is no RBD and there is no GBA mutation, for example, the progression of the disease tends to be slower. While if the RBD is present and the GBA mutation is present, or at least some subtypes of GBA mutations are present, the progression tends to be faster, more cognitive burden, and more non-motor symptom burden. So let's look a little bit about these associations. Cognitive decline. Unfortunately, REM behavior disorder, probably because of this disruption of the sleep function, is associated with a high risk of developing mild cognitive impairment. You see this study in which the patient with RBD without Parkinson had more cognitive decline than the patient with actually already Parkinson's disease, but no REM behavior disorder, and obviously more of normal controls. To the point that some patients with RBD, instead of going toward Parkinson's disease, they go toward Lewy body dementia, which is, as you might know, is a atypical Parkinson's disease, which develops with symptoms that are more similar to Alzheimer's, so more affecting the cognitive sphere, in addition of having some form of tremor, rigidity, and bradykinesia. So patients with RBD are at risk of more severe cognitive decline, or even getting a completely different disease that is called Lewy body dementia. At the same time, patients who have RBD and develop Parkinson seems to have more non-motor symptoms of what we call dysautonomia. What does dysautonomia means? Means that the autonomic function, which is all the function that we don't control, fortunately, because we don't want to control our heart rate or our, respiratory functions. All those autonomic functions that regulate our bowel movements, our exchange of oxygen through the lungs, our heartbeats, and our blood pressure, and so forth, tend to be affected more frequently. They're obviously affected in Parkinson's disease, but more frequently when RBD is part of the story. And so when someone has RBD and autonomic dysfunction, tend to have more risk to develop a neurodegenerative disorder and have more gastrointestinal, urinary, you see cardiovascular function abnormality. And they really are an intermediate between a healthy control and a Parkinson patient. In other words, they don't have a risk factor. They seem to be just a very early stage of what we call Parkinson's disease. But sometimes, similar to what we see for cognition, some patients with RBD, instead of going down the Parkinson route or the Lewy body dementia route, they go down the multiple system atrophy route, which is a rare, fortunately, rapidly progressive neurogenerative disease that does not respond to levodopa and shows a lot of autonomic dysfunction, a lot of blood pressure, orthostatic hypotension, urinary problem, gastrointestinal dysfunction. And this is what we call a typical Parkinsonism, and it's much more severe than Parkinson, unfortunately, and object of many clinical trials and studies, but very frustrating both for patients and caregivers and doctors alike, because we don't have much to offer. But the REM behavior disorder can affect the autonomic function to the point that the patient develop a specific dysautonomia called MSA. So this is a little bit of a graphic summary of all the different possibility. They don't all come all together, fortunately, but someone can develop RBD, and then depending on what other symptoms come together, they come down the Parkinson disease route, the dementia with Lewy body route, or the multiple system atrophy route. And I'm going to take a quick detour to talk a little bit about the research that we are conducting on REM behavior disorder, trying to exploit the window of opportunity that these symptoms give us to try to modify to and change the progression of the disease. This is the MIBG, which is at least in the United States, is a research test, which is the equivalent of the DAT scan that we all know for the dopamine in the brain, for the norepinephrine, for the adrenaline system in the heart. And this MIBG has been found to be abnormal in patients with Parkinson's disease, but also in many other problems, especially heart failure. And this is something that is used very frequently to document and to study autonomic dysfunction in Parkinson's disease. It is, however, also abnormal in REM behavior disorder. And what makes it helpful and useful is that you can see an abnormality of the DATs, of the MIBG, see that the heart is blue. There is no red and yellow activity in the heart of this patient, at the same time as the DAT scan is still normal or very mildly abnormal, which gives you the idea of the window of opportunity, right? We have a problem that is still affecting only the body outside of the brain, while the brain is still holding strong. So that's the window of opportunity. Try to affect the progression of the disease before it starts to affect the brain. And this is just some of our data here at the Cedars-Sinai, in which we had several patients here. Each one of these dots is a different patient who are in the red zone, meaning they're abnormal in the heart. Their heart test is abnormal, but the brain test is perfectly normal, aside of 1 or 2. So they're in the perfect window of opportunity before the brain gets affected. And what we did, I'm sorry for the busy slides, we don't need to go through all this data. What we did was to see whether these abnormalities were a sign of autonomic dysfunction or denervation, as they're often described, or a sign of autonomic overactivation, sort of a stress response. And our data seem to suggest that this autonomic dysfunction is not immediately a denervation, a degeneration, but it seems to be a reaction to something that is going wrong. These people have a sympathetic overactivity. They're stressed. There's autonomic symptoms. Their autonomic system is overactive, is stressed. And in fact, what we did, we gave them some adrenergic blocker treatment. We tried to calm down the sympathetic system, the stress response. And we did, we showed in many of them, you see these lines going down. We showed that we were able to improve in many of them these signs of stress, of stress of the autonomic system. And you see, even the REM behavior disorder questionnaire in many cases seemed to improve. So they had less RBD. Were we on the way to slow down the progression to Parkinson's disease? It's very difficult to say at this stage. Also, not, as you can see, we didn't have too many patients. Maybe I think it was 15, but definitely was a very interesting attempt that we are still ongoing here at Cedars. And why is that very interesting? Because the sympathetic nervous system, the stress response, and inflammation go hand in hand in our body. At the end of the day, what the autonomic system does, in addition to regulate our heart, our bowels, our bladder, is to fight off inflammation. And so the sympathetic nervous system is involved in the control of the immune system. And why is that important? because some of the most probably convincing theories about why Parkinson's disease is starting is due to chronic inflammatory processes that may come from many different triggers. And in fact, there is data that shows that neuroinflammatory medications and immune regulator seems to reduce the chance of having Parkinson's disease. This very elegant study comes from patients with inflammatory diseases that have very high TNF-alpha. TNF-alpha is a cytokine, is the expression of an inflammatory process in the human body. And we see that when people have high inflammation and RBD, they tend to progress faster to develop Parkinson's disease. At the same time, if we treat TNF-alpha, so in patients, for example, with rheumatoid arthritis or Crohn's disease or other inflammatory disorder that need to be treated with strong anti-inflammatories, those people that are treated with anti-TNF-alpha or anti-inflammatories in general seems to have less of a chance to develop Parkinson's disease over their lifetime, which is a very interesting observation that suggests that maybe if we treat patients with RBD, which have a high tendency of have a high inflammatory profile with strong anti-inflammatories, we might slow down the inevitable progression toward neurodegeneration and Parkinson or Lewy body dementia or MSA. And this is exactly what the PSG, Dr. Jesse Cederbaum, is organizing. This is just the title of the study that is currently under, we're setting up. There are a number of study sites. We have been selected as one. And this is something that is not yet, recruiting is not yet available, but might come very, very soon to test this hypothesis in patients with RBD. So to conclude, RBD or REM behavior disorder is the loss of normal REM sleep atonia, which means the paralysis of muscles during the part of the sleep in which we dream, which, however, enables, in the case of RBD, individuals to act out their dreams, sometimes very violently. RBD is now recognized not only as a risk factor for synucleinopathy, for Parkinson's disease and neurodegeneration, but as a very early signs of the disease, other than developing as Parkinson's disease, Lewy body dementia, or MSA. And as we have discussed, this represents a remarkable, amazing window of opportunity to study, obviously, but also possibly modify the progression to neurodegenerative disorder. And this is an illustration that I borrow from the study of Dr. Cedersbaum and Yale. And it's a very interesting concept in my mind that I've been thinking for quite some time. In other words, we always see the idea of neurodegeneration as something that, you know, we're doing well, and then at some point something happened and we start deteriorating. And instead, I think that what happens is that there is a prodromal phase in which the organism tries to fight off something, whether that be aging or some chronic inflammatory process that they may have many trigger. Would that be pesticides, trauma, viral infection, poor diet, metabolic disorders? But there is an attempt to fight. And sometimes the attempt to fight might obviously win, but sometimes may actually turn out to be dangerous for the body and may cause the disease, almost like an autoimmune disorder, and then develop the failure, the neurodegeneration and the symptoms of Parkinson's disease or similar disorder. So this is a very exciting moment because for the first time in my mind, we start to have information that precede the onset of Parkinson's disease and similar neurodegenerative disorder. And we can truly go after them before, literally stop them from happening, and obviously learn also what we can do for those who already have developed the neurological disorder and slow down that progression. And I want to conclude thanking my team at Cedars-Sinai that obviously allows me to share with you all this knowledge. Thank you for your attention.
Thank you so much, Dr. Tagliati. So we do have some questions for you. First of all, going back to when you were talking about the phosphorated alpha-synuclein, we had a question about what is phosphorated? What does that mean?
Oh, thank you. And I apologize for for talking a little bit tech or medicese, so to speak. Phosphorylated means simply that the alpha-synuclein, which is at the end of the day just a protein that is present in many cells in the body, not just in the brain. Sometimes when it gets phosphorylated, when it's attached to a phosphate, it tends to become stickier. And so when we talk about phosphorylated alpha-synuclein, it would indicate that that alpha-synuclein that is found in the degeneration, because instead of working its normal function, instead it starts to stick with other molecule to alpha-synuclein and gets those blobs that we call Lewy bodies, for example. So when we talk about phosphorylated alpha-synuclein, we basically mean abnormal alpha-synuclein, and that's what those tests look for in the skin or in the cerebrospinal fluid.
Okay, so you said that REM sleep behavior disorder is present in Parkinson's disease, Lewy body dementia, and MSA. So this question was, how do we know which route the disease will take?
Very good question. And the honest answer is that at the very beginning, it's very difficult to decide. However, a good physician can, in the early phase, monitor this REM behavior disorder and test, for example, cognitive performance, do some cognitive tests like a MOCA or other cognitive tests, and monitor the autonomic function. And if the cognitive test or the autonomic function seems to go toward an abnormality a little bit early, that might be an early sign that that the REM behavior disorder abnormality is going toward that route. These are very early information. I mean, we're really starting to deal with this symptom as an early, still possible, although pretty well established. As you can see, the current definitions of Parkinson's disease include RBD in them. But how to exactly predict which way we'll take is something that is not known. I mean, we can be more or less intuitive, more or less statistically predictive, but at the personal medicine level, it's very difficult to tell to Mr. Johnson or Mrs. Brown exactly what will happen in the next few years.
This person said, I thought I had restless legs at night, but I might have RBD after hearing this. Are these conditions related?
Very good questions, and very often mixed up, right? So they're actually quite different conditions, and I'll try to quickly differentiate them. So restless legs, which is actually kind of a misnomer because there is no true restlessness, there's no agitation, is a weird sensation of irritability, of uncomfortable, almost tingling numbness that arise at the end of the day, usually toward the evening, and most importantly, when we have to sit still, usually in bed, right before going to sleep, but also on an airplane or at the restaurant or in the theater or in the movie theater. If someone is forced or expected to sit still or to lie still you start feeling kind of the need to do something, and only getting up and walk will relieve this uncomfortable feeling. That is restless legs. So it happens when you're still awake, and it can interfere with sleep because you can't fall asleep. You feel so uncomfortable and nervous, and you have to move, you have to maybe take a bath or do some gymnastics, but you never really fall asleep. That's why it interferes with normal sleep. REM behavior disorder, as we saw, is something that is part of the sleep. You need to fall asleep in order to have REM behavior disorder. And it happens during the night. And most of the time, the patient with REM behavior disorder doesn't even know to have REM behavior disorder. The bad partner is the one that say, you know, you punched me yesterday, or you couldn't stop talking all night. My God, I couldn't close my eyes. Most of the time, patients don't report REM behavior disorder. You have to ask their spouse, or maybe someone who happened to sleep in their house and heard them speaking, or heard strange noises coming from the bedroom. So restless legs, you will feel it. You will know that you're restless. REM behavior disorder will happen most of the time without the patient being aware, unless they fall off the bed or they knock down their bedside table lamp, and then of course they will probably be aware that something happened.
Okay, so you've explained a little bit about what the dream enactment might be like. You mentioned speaking, moving around, maybe punching. Can you talk a little bit about what are the typical things people are dreaming about? If there is a general type of dream that they're having, and is it a progressive thing, meaning it starts off maybe just with speaking and then it progresses to more action during the night? Or is that pretty stable and static through the onset of symptoms?
That's a great question, and I'll be honest with you. I'll take a little bit of disclosure. I'm not a sleep doctor, right? So I have a sort of an acquired interest for RBD. So I'll tell you what I've learned, but maybe a sleep specialist could be even more specific than me. But there are a lot of patients that never go beyond talking in their sleep, and in fact, I've seen that describe also like a REM type activity, is not as a REM behavior disorder, that then after sometimes can become a full-fledged REM behavior disorder. But many specialists like to define only talking or maybe yelling a little bit in sleep, not as a full-fledged REM behavior disorder. REM behavior disorder is really when there are movements, not just vocalizations. And very often, I had many patients that reported that to me. The dreams are quite scary and violent and vivid, and you're fighting someone. There is actually a very funny comedian. His name is Mike Birbiglia. If you want to have a funny recount of RBD, go to get on YouTube his monologues. He's super funny, and he talks about fighting a bear and then doing something very, very dramatic. But they're usually quite vivid and violent, and that's why, as you've seen in that video that I show you, you know, that gentleman seemed to be literally fighting someone with his pillow. That for some reason the dreams are not your nice sweet dreams. They're quite violent and stressful and agitated. In fact, REM behavior disorder, among other things, usually in younger people, can be triggered by intense stress. If people are really stressed, can have occasional episodes of REM behavior disorder. But when we analyze them, when we study them, they don't have that inflammatory excess, that stress response excess that we see in people with idiopathic REM behavior disorder.
I'm going to kind of add on to that. Are there gender differences in how people act out their dreams? meaning are the men generally kind of the typical more active, more, physical than women?
So the answer to your question is yes, with a little caveat, because preparing for this lecture, I read that there might be a gender bias in so men tend to agree to have a sleep study for some reason more often than women. So we might have more information about RBD in men than we have for women. And I read a caution in one of the studies that I was reviewing that when you control for the number of studies that you actually have in men and in women, is not much different. Like it might be less of a difference. Now, we know that Parkinson's disease seems to be more frequent in men than women, 2 to 1, more or less. Every one woman, there are 2 men with Parkinson's disease. So it might be intuitive to decide that there is more RBD in men than women, but the jury is still out for that. I'm not sure, reading what I read, that we know everything about it.
All right. So a couple more real quick questions before we end. So, and some of these are about sort of like leading up to having RBD. So one question came in earlier about if someone, or is there any connection between, as a child, someone maybe sleepwalking or being a significant bedwetter as a child, then having a more risk factor for RBD as an adult?
Not that I know of. Not that I know of. It's quite common, and it's probably a different. There is a difference between this sleep abnormalities, parasomnias, as they're called, at the young age and after age 50. And I'm not aware, and definitely in my experience with my patients, which I interview daily about the possibility that they might have REM behavior disorder. This should be a routine part of the interview in the Parkinson clinic. And I have not perceived, although I've not researched it, formally, a connection between sleepwalking as a kid or having night terror as a kid and then developing REM behavior disorder. It seems to be an acquired, or maybe in some cases we saw GBA with some genetic predisposition, but mostly an acquired aging problem.
In one of your earlier slides, you mentioned sleep apnea as a prodromal symptom. What might the cause of sleep apnea in early stages of, or what might be the cause of sleep apnea in early stages of Parkinson's?
So sleep apnea is a big problem with Parkinson's disease, at least in my experience. I have many patients with Parkinson's disease that have sleep apnea. Many times they don't even know about it. There is a parallel track similar to RBD, and in fact many, though it's controversial, but many consider sleep apnea a risk factor for Parkinson's disease. If not, maybe at some point we'll consider it an early symptom. What is this? What is the cause or the risk for the sleep apnea? Everybody knows about obesity and being overweight, but I have many patients with Parkinson's that have sleep apnea without being overweight. And so I don't know if that stress reaction, if that inflammatory process that we mentioned briefly and that now are a matter of study might explain both function, but it's still something very poorly characterized, the correlation between sleep apnea and Parkinson's disease.
Well, Dr. Tagliati, this has been so extremely interesting. And Thank you, Kelly. She dropped a survey in there, but actually I would love to ask the audience, because you've given us so much information today, a couple of quick poll questions. We like to kind of determine, what you might have learned from this and how this might have helped you in some way. So Kelly's going to pop up 2 quick poll questions, whether this program did improve your knowledge on this topic. So if you could take a quick moment to answer that poll question, and then we'll go to the next one. And in the meantime, we want to do a deeper dive in your experience. If you're someone who is at risk or is experiencing a prodromal symptom, we would love to have some insights from you. And the survey link has been dropped in the chat. You can do that on your own time, but would love to get some feedback from today's program. We really appreciate all of the time and attention to subject. I know I learned quite a few new things today from Dr. Tagliati. Okay, and then I think that maybe we can go on to the second poll question real quick, Kelly.
Well, the poll question should be showing up if you scroll down.
Oh, okay, sorry. Here I am trying to.
Oh,
Wonderful.
That's yeah, we didn't make
Awesome.
that clear that they're one over the other. So
Yes, thank you for that clarification. And while everyone is completing that, I will just remind you that we do have these programs specific for our proactive brain health community. So we'll be kicking back off into 25, and we'll ask you to keep your eye out for those programs. And you may have attended our Space Between program. This is for those who are identified as at-risk or prodromal and want to get together in community and ask questions from movement disorders experts. And we will be having another one of those. Those are quarterly. And we do this in partnership with C&D Life Sciences. So we're so thankful to them and for you all joining us in. So I want to thank you, Dr. Tagliati, for today. This has been an incredible talk. I learned so much new information from you.
Thank you for having me. And thank you all for being here until the end.
Absolutely. And thank you everyone for joining us, and love to show some love and gratitude to Dr. Tagliati with a wave. And in the meantime, I want to wish everyone a happy and safe holiday season.
Happy holidays to everybody.
Bye.
Bye-bye.